Hello everyone, I am Sarah Senno and I will be giving the lectures on gastrointestinal pathology. There will be a total of 5 lectures, and in this lecture we will start with the pathology of the esophagus. There are different learning outcomes that we aim to achieve in this session, and these are: you should be able to list the common anatomic and congenital disorders affecting the esophagus. You should be able to describe the common causes underlying esophageal obstruction and to distinguish the different types of esophagitis, to be able to identify Barrett esophagus and esophageal varices, and to explain the pathophysiology underlying the most common esophageal neoplasms. So this is the outline that we will follow in order to achieve the learning outcomes. So we will start with the normal esophagus. We will briefly review the anatomy and histology. The esophagus is a tubular, elongated organ of the digestive system, which connects the pharynx to the stomach. It is about 23 to 25 centimeters long in adults, with sphincters located at each of its proximal and distal ends. The upper esophageal sphincter allows for the single direction passage of food into the esophagus, and the lower esophageal sphincter allows for the single direction passage of food into the stomach. The lower esophageal sphincter, crural diaphragm, and phrenoesophageal ligament function as an anti-reflux barrier to gastric contents. This slide describes the anatomic location of the esophagus. As we can see, it is located behind the trachea and the heart and in front of the spinal column. The esophagus passes through the diaphragm through a hiatus. A hiatus is an opening before it enters the stomach. So here in this slide, we can see the gross appearance of the esophagus. So this is the normal esophagus. Normally it has a white to tan mucosa. And here we have the stomach, and which empties into the duodenum. This is a higher magnification view of the normal gastroesophageal junction. The esophageal wall is divided into 4 layers. The innermost layer is the mucosa, which consists of non-keratinizing stratified squamous epithelium. Beneath the mucosa is the submucosa, which consists of connective tissue. Beneath it is the muscularis propria. The proximal one-third of the muscularis propria consists of skeletal muscle, while the distal two-thirds consists of smooth muscle. The outermost layer is the adventitia. In this slide, we can see the histology of the normal esophagus. We can appreciate the different layers of the esophageal wall. The inner layer, we have the mucosa, which consists of stratified squamous epithelium that is non-keratinizing. Below it, there is the submucosa, where we can also see mucus glands within it. Under it, there is the muscularis propria, which consists of bundles of muscle. And then there's the adventitia, which is not seen in this picture. And this picture shows the stratified squamous mucosa that is non-keratinizing. This is a higher magnification view. Now we will talk about the anatomic disorders that affect the esophagus. These include congenital disorders such as atresia and fistulas, and we will also talk about hiatal hernia. In esophageal atresia, a segment of the esophagus does not develop, leaving a thin, non-canalized cord, so food cannot pass through, leading to mechanical obstruction. Atresias commonly occur with a fistula. A fistula is a connection between two body parts. In this picture, we can see the different types of esophageal atresias and fistulas. So in A, there is only esophageal atresia. There is no fistula. Here, we can see that there is esophageal atresia and there is a proximal tracheoesophageal fistula. In C, this is the most common scenario. There is esophageal atresia with distal tracheoesophageal fistula. In D, there is esophageal atresia with both proximal and distal tracheoesophageal fistulas. And in E, there is no atresia, there is only fistula, so it is also called H-type fistula. Atresia and fistulas are the most common congenital disorder affecting the esophagus. They are discovered shortly after birth, usually due to regurgitation during feeding. Most are incompatible with survival without prompt surgical repair. They can lead to aspiration, suffocation, pneumonia, and severe fluid and electrolyte imbalances. They are associated with a range of congenital abnormalities termed factorial, which refers to malformations including vertebral, anal, cardiac, tracheoesophageal, renal, and limb defects. Now we will talk about hiatal hernias. A hiatal hernia, it occurs when the stomach herniates upward through the esophageal hiatus of the diaphragm, and this can lead to gastroesophageal reflux. There are two types of hiatal hernias. The most common type is the sliding hiatal hernia, also referred to as axial hiatal hernia. In this type, part of the stomach herniates above the diaphragm. However, this part that herniates is bounded below by the narrow diaphragmatic opening, and the gastroesophageal junction in this type is displaced upward as the gastric cardia slides into the hiatus. In the next slide, we will see a picture describing this. The second type of hiatal hernia is the paraesophageal or non-axial, also referred to as rolling. This occurs in about 5% of hiatal hernias. In this type, part of the stomach herniates into the thoracic cavity through the widened foramen. The gastroesophageal junction in this type remains in its place. This slide illustrates the hiatal hernias that we have just discussed. So here we can see the normal stomach and the normal gastroesophageal junction. In sliding hiatal hernia, the gastric cardia slides into the hiatus, and the gastroesophageal junction is displaced upward. In paraesophageal hiatal hernia, the gastroesophageal junction remains in its place, but the gastric fundus protrudes into the thorax. Now we will discuss the different causes behind esophageal obstruction. Obstruction can be partial or complete, and the causes behind esophageal obstruction can be anatomic or physiologic. Anatomic causes are when there is something physical causing obstruction or narrowing, and these include strictures, webs, rings, diverticula. Or the obstruction can be something physiologic, such as in achalasia. A stricture is a stenosis or narrowing of the lumen. Esophageal strictures can be benign or malignant. Malignant strictures occur when there is a malignant neoplasm growing into the lumen of the esophagus, causing obstruction. Benign strictures are due to fibrosis and scarring, and this fibrosis commonly occurs due to chronic inflammation, as occurs in chronic gastroesophageal reflux. Fibrosis can also occur due to radiation or caustic injury. Esophageal webs are thin membranes of tissue composed of mucosa. They protrude into the lumen. They are semi-circumferential, and they usually occur when there is long-standing inflammation. Plummer-Vinson syndrome is defined by the classic triad of esophageal webs, dysphagia, and iron deficiency anemia. Glossitis is also present in those patients, and glossitis is usually atrophic, where there is atrophy of the lingual papillae, so the tongue will have a smooth, shiny appearance, and it can be painful. Plummer-Vinson syndrome is important to recognize because it identifies a group of patients that are at increased risk of squamous cell carcinoma of the pharynx and the esophagus. Esophageal rings, also known as Katsky rings, are similar to esophageal webs. However, they are thicker and are circumferential. They usually occur in the distal esophagus. In this slide, we can see an esophageal web on the left and an esophageal ring on the right. The esophageal web consists of semicircumferential mucosal tissue that protrudes into the lumen, whereas the esophageal ring is circumferential. Now we come to esophageal diverticulum. But first, what is a diverticulum? A diverticulum is an outpouch of the alimentary tract. In the esophagus, there are three main types of diverticuli. The Zenker diverticulum, which occurs above the upper esophageal sphincter, also known as the pharyngoesophageal diverticulum. There's also the traction diverticulum, which occurs in the mid portion of the esophagus, and there is the epiphrenic diverticulum, which occurs above the lower esophageal sphincter. Now back to Zenker diverticulum. It is a false diverticulum. We mean by a false diverticulum is that the outpouch consists only of mucosa. It does not consist of all the layers of the esophageal wall. The Zenker diverticulum can acquire a large size, and it can accumulate a large amount of food, producing a mass. Symptoms include dysphagia, which is difficulty swallowing, halitosis, which is bad breath, and aspiration. So what is the pathophysiology behind Zenker diverticulum? Why does it form? It occurs when there is excessive pressure within the lower pharynx, and this will lead the weakest portion of the pharyngeal wall to herniate out. So the mucosa will herniate posteriorly, forming a diverticulum. It is caused by cricopharyngeal motor dysfunction, and it usually occurs after the age of 50. Now we will discuss a physiologic cause of esophageal obstruction, and we will talk mainly about achalasia. Achalasia refers to failure of the smooth muscle fibers of the gastrointestinal tract to relax. So failure to relax. This is opposed to chalasia, which refers to relaxation of a body opening. So achalasia is characterized by a triad of incomplete lower esophageal sphincter relaxation, increased lower esophageal sphincter tone, and aperistalsis of the esophagus. Causes of achalasia can be primary or secondary. Primary causes are due to changes in neural innervation of the esophagus, whereas secondary causes include trypanosome cruzi infection, which destroys the mesenteric plexus of the esophagus, leading to Chagas disease. Now we will talk about esophagitis. There are many types of esophagitis, including chemical, infectious, reflux, eosinophilic. Esophagitis refers to inflammation of the esophagus. Before going into the different types of esophagitis, we will first briefly discuss lacerations that occur in the esophagus, and the most common type is the Mallory Weiss tears. And these are longitudinal tears that occur within the mucosa and near the gastroesophageal junction. The most common cause is severe vomiting, which occurs due to in cases, for example, of acute alcohol intoxication. Other causes include trauma and iatrogenic injury, such as by medical instrumentation. Mallory Weiss tears can lead to upper gastrointestinal bleeding and hematemesis. In this picture, we can see Mallory Weiss tears near the gastroesophageal junction. We will start with chemical esophagitis, which occurs as a result of ingestion of irritants and certain drugs. Examples of irritants include alcohol, acids and alkalis, very hot fluids, household cleaning products. Examples of drugs that can cause chemical esophagitis include cytotoxic anti-cancer drugs, and some pills which cause pill-induced esophagitis. These include iron tablets and bisphosphonates. Bisphosphonates are used to treat osteoporosis. Radiation therapy can also cause esophagitis. Esophagitis can occur as a result of an infection, and the most common infections are fungal and viral. And the infectious esophagitis usually occurs in immunocompromised patients, such as patients with AIDS or patients taking immunosuppressive drugs. The most common cause of infectious esophagitis is Candida infection. By endoscopy, it will appear as adherent gray-white pseudomembranes. We will see a picture of it in the next slide. Under the light microscope, Candida appears as fungal pseudohyphae and spores. Viruses that cause infectious esophagitis are herpes simplex virus and cytomegalovirus. By endoscopy, HSV appears as punched out ulcers, while CMV appears as shallower ulcer. This picture illustrates the white pseudomembranous plaques that are characteristic of Candida infection. So when we see this appearance, we would highly suspect Candida infection. Under the light microscope, Candida will appear as fungal pseudohyphae and spores. So here this is an example of a pseudohyphae, and here we have pseudohyphae, and here we have spores. So, pseudohyphae are not true hyphae. They are chains of elongated yeast cells, and they result from incomplete budding when the cells fail to detach after each cell division and continue to elongate. In this picture, we can see numerous fungal pseudohyphae. These are pseudohyphaes, and spores. These are the spores. Okay. This is a picture of herpes esophagitis, where we can see multiple punched out ulcers. Herpes simplex virus usually infects the squamous epithelial cells, so the viral cytopathic changes will be seen within the squamous epithelial cells. The viral changes characteristic of HSV are multinucleation, where the cell will have more than one nucleus. And so this is the first M, multinucleation, nuclear molding. So this is the second M, molding, which means that the nucleus will conform to the shape of the adjacent nucleus. So it will bend and it will take the shape of the adjacent nucleus. And the third M is margination of the chromatin, which means that the chromatin will go to the periphery. It will marginate to the periphery of the nucleus. Because in the center, so we have the three, in the center there will be the intranuclear eosinophilic inclusion, also termed as Cowdery type A inclusion. So you have the three M's, multinucleation, molding, and margination of chromatin. And in addition, there's the intranuclear eosinophilic inclusion called Cowdery type A inclusion. So this is another picture that shows the viral cytopathic changes that occur within the squamous epithelial cells as a result of HSV infection. So as we said in the previous slide, we have multinucleation, molding, margination of chromatin, and we can see the Cowdery type A inclusions. Cytomegalovirus, on the other hand, usually infects endothelial cells and mesenchymal cells beneath the mucosa, as opposed to herpes, when we said it most commonly infects the squamous epithelial cells. The changes, the viral cytopathic changes seen in cytomegalovirus include the cell will enlarge, so it will become big, and the nucleus will enlarge too. and there will be a large intranuclear eosinophilic inclusion. So it will look like an owl eye. Also, there will be multiple smaller, very small basophilic cytoplasmic inclusions. This here we can see CMV infected cells. You can see the inclusions within the cell and how the cell is enlarged. Now we will talk about reflux esophagitis. Reflux esophagitis, it is the most frequent cause of esophagitis. It is also known as GERD or gastroesophageal reflux disease. It is due to reflux of the gastric contents up into the lower esophagus. And this is usually caused by transient lower esophageal sphincter relaxation. Even though the esophageal squamous epithelium is resistant to the abrasive injury from food, it is, however, sensitive to acid. So when there is reflux of the gastric contents which are acidic into the esophagus, this will cause esophagitis. And if the esophagitis is persistent, this can lead to ulceration, and it can also cause fibrosis, which is a complication of reflux esophagitis, and fibrosis can lead to a stricture. Barrett esophagus is also another complication of reflux esophagitis. We will discuss Barrett esophagus in the next slides. In reflux esophagitis, inflammatory cells are usually seen within the squamous epithelium. Examples of these inflammatory cells, we have the eosinophils, which we commonly see in cases of reflux esophagitis, and neutrophils. Now we will talk about eosinophilic esophagitis, which is an uncommon cause of esophagitis. Eosinophilic esophagitis refers to eosinophil-dominated esophageal inflammation, which means that there will be numerous eosinophils within the squamous epithelium, much more eosinophils than we see in reflux esophagitis, and it is usually associated with atopic disease. Atopy refers to the genetic tendency to develop allergic diseases such as allergic rhinitis, asthma, atopic dermatitis, or eczema. Eosinophilic esophagitis is not associated with increased risk of Barrett esophagus, unlike reflux esophagitis. This is a picture of eosinophilic esophagitis, where we can see numerous aggregates of eosinophils within the squamous epithelium. Now we will discuss Barrett esophagus. Barrett esophagus occurs as a result of chronic gastroesophageal reflux disease. So it is characterized by the presence of intestinal metaplasia. So the squamous epithelium at the gastroesophageal junction undergoes intestinal metaplasia. It will first become columnar and then goblet cells will occur. So in intestinal metaplasia, goblet cells are present. And it is very important to recognize Barrett esophagus because the patients are at increased risk of developing dysplasia and subsequently esophageal adenocarcinoma. Barrett esophagus can only be diagnosed through endoscopy and biopsy. So you need a biopsy in order to diagnose Barrett esophagus. So, as we said, because patients with Barrett esophagus are at increased risk of later developing dysplasia and carcinoma, these patients should be periodically followed up with endoscopy and biopsy. By endoscopy, Barrett esophagus will appear as tongues of red velvety mucosa extending upward from the gastroesophageal junction. So here in this picture on the left, we can see the normal gastroesophageal junction where the squamocolumnar junction lies directly at the gastroesophageal junction. Whereas in Barrett esophagus, as we see in the picture on the right, The columnar appearing mucosa extends upward into the distal esophagus, so the squamocolumnar junction will be proximal to the gastroesophageal junction. In this slide, we can see the endoscopic appearance of Barrett esophagus, where there are tongues of red velvety mucosa extending upward from the gastroesophageal junction. And this pale mucosa here is the normal esophageal mucosa. In this slide, we can see microscopic pictures of Barrett esophagus, which occurs, as we said, at the gastroesophageal junction. We can see the intestinal metaplasia, where we can see the columnar cells, and more importantly, we have the goblet cells. So these are goblet cells. Goblet cells are normally seen in the small and large intestines. Before proceeding to esophageal neoplasms, we will just briefly discuss esophageal varices. Esophageal varices refer to the presence of dilated and tortuous veins within the mucosa and submucosa, and they usually occur within the distal esophagus and proximal stomach, and they usually occur in the setting of portal hypertension. In portal hypertension, there will be shunting of blood from the portal circulation to the systemic circulation, and this can cause varices within the esophagus. Portal hypertension usually occurs when there is liver cirrhosis, which means advanced fibrosis of the liver. Esophageal varices, the significance of them is that they may rupture, and this can lead to bleeding, and this bleeding can be massive and sometimes fatal. This picture shows esophageal varices where there are dilated purplish veins located in the distal esophagus and at the gastroesophageal junction. These varices, as we said, can be a source of bleeding and hematemesis. Finally, we come to esophageal neoplasms. In the esophagus, the majority of tumors are malignant. So the most common malignant tumors in the esophagus are squamous cell carcinoma and adenocarcinoma. And in this lecture, we will discuss these two most common types of cancers within the esophagus. These two carcinomas have a poor prognosis because of the advanced disease at presentation. They pursue an aggressive course because, as you remember, as we said in the beginning of the lecture, the esophagus lacks serosa in the esophageal wall. It has an adventitia instead, and this allows rapid extension of the tumor. This slide illustrates the risk factors for developing esophageal squamous cell carcinoma, and these risk factors include alcohol, tobacco, caustic injury, which can be caused by strong acids and alkalis, achalasia, Plummer-Vinson syndrome, consumption of very hot beverages, etc. Esophageal squamous cell carcinoma is the most common type of esophageal carcinoma worldwide. Half of them occur in the middle third of the esophagus. This is as opposed to esophageal adenocarcinomas, where the majority of esophageal adenocarcinomas occur in the distal esophagus. Squamous cell carcinoma begins first as squamous dysplasia. So squamous dysplasia is the precursor of squamous cell carcinoma, and it is an in situ lesion. So first you have normal squamous mucosa, and if it develops and acquires additional mutations and genetic alterations, it will turn into squamous dysplasia, which is in situ, and then with the accumulation of additional mutations and genetic alterations, it will progress into squamous cell carcinoma, invasive squamous cell carcinoma. These tumors have a variety of gross appearances. They can appear as an exophytic polypoid mass that is protruding into the lumen, or they can be ulcerated, or they can grow inwards, and infiltrate within the esophageal wall, causing thickening and rigidity of the esophageal wall and leading to narrowing of the esophageal lumen. As all carcinomas, they are graded, and grading is based on the degree of differentiation, as seen by the microscope. Well-differentiated tumors are easy to recognize as squamous in origin, while poorly differentiated tumors, on the other hand, have no evidence or very minimal evidence of squamous differentiation. Moderately differentiated tumors are in between. There is evidence of squamous differentiation in them. These tumors invade into the esophageal wall. If they invade throughout the entire thickness of the wall, they may sometimes continue to invade into surrounding structures, such as the respiratory tree, leading to pneumonia. They may invade into the aorta, causing exsanguination, the mediastinum, and pericardium. Carcinomas are staged. Stage is the most important prognostic factor. It is characterized by the T, N, and M. The T is determined by the extent of invasion into the esophageal wall and if it invades into surrounding structures. The N is determined by the presence or absence of lymph node metastasis, and the M is determined by the presence of or absence of distant metastasis. Metastasis occurs through lymphatic spread. Esophageal carcinomas have poor prognosis and survival. This picture shows a mass located in the mid-esophagus. It is exophytic and ulcerated. In this slide, we can see invasive squamous cell carcinoma where we have invading squamous cells that are atypical. And in this example, it is keratinizing, so there are keratin pearls that are being formed. Now we come to esophageal adenocarcinoma. So unlike squamous cell carcinoma, esophageal adenocarcinoma arises in the background of Barrett esophagus and long-standing gastroesophageal reflux disease. Therefore, the risk factors for esophageal adenocarcinoma include chronic gastroesophageal reflux disease and Barrett esophagus, in addition to tobacco and exposure to radiation. Conversely, the risk of carcinoma is reduced by diets rich in fresh fruits and vegetables. So as we previously said, since esophageal adenocarcinomas occur usually in the distal esophagus, they may invade the adjacent gastric cardia. Progression from Barrett to adenocarcinoma occurs through a stepwise acquisition of genetic and epigenetic changes, as we will see in the next slide. And these changes include mutations in p53 and CDK and 2A. This slide illustrates the stepwise progression from normal esophagus to esophageal adenocarcinoma. So chronic inflammation of the esophagus, as occurs in chronic reflux esophagitis, can lead to intestinal metaplasia or Barrett esophagus. With time, with the accumulation of additional genetic mutations and chromosomal abnormalities, this will progress into low-grade dysplasia, which can further progress into high-grade dysplasia. When we are talking about dysplasia, we are talking about in situ lesions. If this lesion further accumulates genetic abnormalities, it may progress into invasive adenocarcinoma. This slide shows a picture of esophageal adenocarcinoma where there are big exophytic masses located at the gastroesophageal junction and they are protruding into the lumen. Alternatively, tumors may not form exophytic masses and may instead diffusely infiltrate through the wall. This is a microscopic image that shows esophageal adenocarcinoma where there are invasive glandular structures composed of atypical cells and they are infiltrating through the wall. This concludes the lecture. In this lecture, we have discussed the various pathologies that affect the esophagus, from anatomic disorders that can lead to obstruction. We then discussed the different types of esophagitis, and then we discussed the common esophageal carcinomas. Thank you for your attention.